Good afternoon. Medicaid Health Plans of America is pleased to co-present with HMS this webinar on the impact of Medicaid recovery audit contracts on managed care plans. Our objectives for today's webinar are, first, to share with you what we know about Medicaid RACs. Second, to educate Medicaid managed care plans, or MCOs as we'll call them, and also increase their awareness on the issues. And third, to encourage MCOs to think proactively about how RACs may potentially affect them. I'll start by giving some relevant statistics. On July 7th of this year, CMS released their annual report on Medicaid managed care enrollment. It showed that Medicaid health plan enrollment grew by almost 2.4 million members in 2009, thus reaching more than 23.4 million Americans nationwide. It's no secret that states are increasingly turning to Medicaid health plans to manage benefits in their Medicaid programs. They know that these health plans help in coordinating care and improving quality. And they also allow the Medicaid program to offer benefits at a lower, more predictable cost than the traditional fee-for-service Medicaid program. While growth in Medicaid enrollment increased 7% from June of 2008 to June of 2009, enrollment in Medicaid health plans has increased by more than 11%. Today, about 47% of all Medicaid beneficiaries are now enrolled in a Medicaid health plan. In addition, Medicaid health plans also serve most of the children in CHIP programs throughout the country, and those numbers are not reflected in these statistics. So what does the future hold? Well, projections show that Medicaid enrollment will grow by between 16 to 24 million individuals beginning in 2014. That's the year Medicaid expansion in the healthcare reform law takes full effect. Medicaid health plans are well positioned to serve many of the new enrollees. Health plans add value to Medicaid by providing access to a medical home that's managed by a primary care provider and includes a broad network of other providers that meet both cultural, medical, and social needs of its enrollees. Here's a quick overview for those of you who may not know how this works. Each individual health plan contracts with the state to provide services to its Medicaid members. The plan is paid a capitated rate and in turn offers a network of providers to service their members. Providers are then paid either on a subcapitated rate or on a fee-for-service basis, or some combination thereof. The health plan is held at risk for the cost of care because they're paid a fixed fee that is based on the capitation rate times the number of members that they serve. If this amount is greater than the total claim expense, then they'll have a positive cash flow. So what does all this mean? For one thing, program integrity initiatives become just as important on the MCO side as they are on the fee-for-service side of the Medicaid program. Even though the Affordable Care Act is silent on how many of the program integrity provisions apply to MCOs, it's safe to say that most states will want to implement these new requirements across the entire Medicaid program as a way to contain costs. And also, by implementing this, they can also strive to eliminate fraud, waste, and abuse. That's why we're holding this webinar, to inform MCOs as Medicaid RACs are beginning to become more prevalent across the country. Joining me today to address the issues are Erica Pierce, HMS's Director of Federal Government Relations, and Phyllis Hartstein, Vice President for HMS's MCO Business Unit. Erica will cover what the Affordable Care Act says about Medicaid RACs and explain current CMS guidance. Phyllis will then discuss the significant implications that the RAC program has for MCOs. So let's get started. Erica?
Let's start with an overview of what the Affordable Care Act says about Medicaid RACs. Then we'll cover what CMS has released through guidance and a proposed rule. Section 6411 of the Affordable Care Act expands the current Recovery Audit Contractor programs, better known as RACs, to Medicaid and Medicare Parts C and D. Specifically, the law requires states to contract with one or more Medicaid RACs to identify overpayments and underpayments and to recover overpayments on a contingency fee basis. Before we go deeper into these new requirements for Medicaid, let's take a step back and briefly discuss how RACs originated. The RAC started as a Medicare demonstration project implemented in 2005 in 3 states, California, New York, and Florida. This initial effort by CMS aimed to determine whether RACs would be a cost-effective way to ensure correct payment to providers and suppliers that bill claims for Medicare Part A and Part B reimbursement. Even though this program caused provider concerns with regard to recovery protocols and appeal rights, the RAC contractors reportedly recovered $900 million in overpayments during the demonstration period. Based on this success, in 2007, CMS directed that Medicare RAC process be rolled out nationwide. How do the Medicare RACs work? First, they receive a contingency fee for their recoveries post-appeals. Second, they identify both overpayments and underpayments, although the vast majority of corrected claims have been based on overpayments. Finally, Medicare RACs focus on post-pay review of claims and are expected to follow all regulations and manuals, just like any other reviewing contractor already in place. That brings us to the Medicaid program. As part of the Obama administration's efforts to reduce overpayments, the RAC model is now required to be implemented in the Medicaid claiming environment. There are, however, many important differences between Medicare and Medicaid RACs. The most significant difference, of course, is that unlike Medicare, Medicaid programs are state-administered. For this reason, CMS is allowing flexibility in how states design their Medicaid RAC programs. CMS recognizes that states already conduct several types of post-pay claim audits for Medicaid and indicates that Medicaid RACs are supplemental to these efforts. So Medicaid RACs are required to coordinate their efforts with other contractors and entities already performing provider audits in the state. So when do Medicaid RACs need to be implemented? Well, there's been a lot of activity around this issue over the past few months, largely due to the impending deadline set by the Healthcare Reform Bill and CMS's initial guidance. Originally, the Affordable Care Act called for states to have a Medicaid RAC in place by December 31, 2010. However, a letter about Medicaid RACs that CMS sent to state Medicaid directors on October 1st clarified things. It directed states to submit a state plan amendment to CMS by December 31st and fully implement their programs by April 1st, 2011. In addition to this letter, CMS held a webinar for states on October 28th in which they provided a draft statement of work that states could use in developing RAC RFPs. Then, on November 10th, CMS released a proposed rule on Medicaid RACs, which remains open for comment until January 10, 2011. Links to these CMS communications will be available on HMS's website after this presentation. So far, all of the communications from CMS have been silent on how MCOs will be impacted by the implementation of the Medicaid RACs. Before Phyllis goes into detail about this in her presentation, I'll focus on what the known requirements are on the fee-for-service side. Medicaid RACs are only to be paid on a contingency fee based on the overpayment amounts actually recovered from providers. States have latitude to define the payment method for services to identify underpayments to providers. Are there exceptions to this rule? Well, the rule allows states to seek exceptions to some or all of the Medicaid RAC contracting requirements, but it's clear that CMS will rarely grant complete exceptions and only under the most compelling circumstances. We're aware that some states with heavy managed care populations have sought advice from CMS about whether they should be exempt from the Medicaid RAC program. Outside of these items, it's CMS's intention to give states flexibility in the design of their Medicaid RAC programs. From a scope of work comparison, we should note that Medicare RACs were primarily focused on hospital clinical reviews. The intention of the Medicaid RAC program is to leverage a much broader and robust audit program. In fact, some states have already reached out to CMS and have been given feedback that CMS is not likely to approve a Medicaid RAC that does not take into account services such as home health, hospice, DME, long-term care, and home and community-based waiver services. Further, as CMS focuses on the prevention of fraud, they are increasing their intention to excluded providers. this issue may well become an important part of the RAC initiative. The rule requires states to have an adequate appeals process in place for providers to challenge adverse Medicaid RAC determinations. Medicare RACs have only one appeals process that applies to every state, and provider appeals are made directly to CMS. With Medicaid RACs, the state will manage the appeals process, which means the process may vary from state to state, and not only can providers appeal to the state, but the state can also appeal to CMS. Remember that on the subject of underpayment, states are not required to pay Medicaid RACs on a contingency fee basis. Each state is given discretion to determine its own fee structure for identifying underpayments. CMS has made it clear, though, that the identification of underpayments must be within the scope of every Medicaid RAC program. So what savings do RACs promise? CMS's Office of the Actuary estimated the potential impact of the Medicaid RAC program on federal Medicaid costs and savings. Though these estimates are said to be highly uncertain, you can see from the chart on your screen that CMS believes the program should result in substantial savings over the next few years. Regarding federal funding, the rule states that the federal government will pay 50% of the administrative cost of operation and maintenance of every state's Medicaid RAC program. Now I'll turn the presentation over to Phyllis. She'll go into detail about the potential impact that Medicaid RACs will have on Medicaid MCOs and the questions MCOs should be thinking about going forward.
Thanks, Erica. We believe that Medicaid RAC programs will have significant implications for MCOs. As Thomas mentioned, MCOs comprise 47% of the Medicaid membership, and this is expected to increase substantially by 2014. Although the RAC legislation is silent regarding MCOs, it is unlikely that CMS will leave out the fastest growing component of the Medicaid population for long. In fact, 3 recent Medicaid RAC procurements formally addressed MCOs via the deliberate inclusion or exclusion of auditing encounter data. For those of you who are new to Medicaid managed care, an encounter claim is essentially a report of each service provided by an MCO to a member, and these services are reported to the state as an encounter. To date, the 10 states you see here have issued Medicaid RAC or RAC-like audit RFPs. We expect that in the coming weeks, more states will be issuing these types of RFPs. Incidentally, at least 8 other states, to our knowledge, had program integrity, contingent fee, RAC-like contracts already in place prior to the Affordable Care Act. These contracts are to identify, validate, and recover Medicaid overpayments and provide appeals support. Let me walk you through what we're seeing in some of the states that have issued RAC procurements. Utah specifically excluded auditing MCO claim encounters from the RAC audit scope for all claims where the Utah MCOs were at risk. On the other hand, Tennessee and New Mexico both included auditing the MCO encounters as part of the scope of the RAC audit. In these states, many contractors asked clarifying questions around timetables and business rules regarding the encounter claims. In both Tennessee and New Mexico, the MCOs are at risk for all claim payments, and accordingly, the MCOs routinely perform program integrity post-payment audits. With the state Medicaid agencies including encounter claims as part of the state-directed RAC audits, several coordination efforts must be addressed in the near future. So, what questions should MCOs be asking themselves?